So right now, we'll be discussing about COPD. That's chronic obstructive pulmonary disease. Now, COPD tayo ha. Okay. Now, COPD was formerly known. Ang dating pangalan niya is COLD. Now, sige, history tayo. Historically speaking, okay, tinatawag siyang invincible killer, by the way, no? Now, ito, air pollution may not always be visible, but it can be deadly. Ayan, nakalagay, 43% of deaths from COPD or pulmonary disease actually is air pollution. Now, therefore, living in the world of air pollution right now, okay, we are can be bothered by this problem na alam mo, isang nangyari lang, no? Okay, kasi laging bad news tayo sa ano, no? Laging bad news sa naririnig about the COVID-19 and so on and so forth. Alam nyo, okay, sa totoo lang ang nakaka-recover ngayon yung Earth, no? Kasi siyempre yung nag-lockdown, imagine I have well, it's needed in Manila. Kailangan namin dito ng kotse, no? Okay? Like most parts actually. Na I have 4 cars, no? Nagagamit yan lagi yung mga kotse na yan and so on. Okay? So ngayon, nung nag-lockdown, wala kami magamit kahit isa. So imagine yung ini-emit ng kotse ko ng mga pollution, okay, natanggal for how many months, no? Itong recent lang, ginagamit na isang car, nagka-problema ako sa isang kotse dahil hindi na-start. Na-drain yung battery, no? Okay. In other words, there's always good news in a negative news actually. But again, okay, with what's happening around talaga na overshadow na negative yung positive. So again, guys, I encourage you to stay positive. Okay, not positive for COVID, but positive for circumstances, na. Okay, kaya natin to, lalabanan natin ng COVID-19, na. At that. Anyway, okay, let's go discuss na. So invincible killer siya. That, okay, ang dating pangalan niya, guys, COLD. That stands for chronic obstructive lung disease. Nung COLD pa siya, okay, kasama yung asthma dati, yes. Hindi ever nawala yung asthma, ha? So, kasama yung asthma, yes, kasama yung asthma. Now, okay, ulitin ko. Teka, kasama yung asthma dati, ha? Oops, ayaw niya magsulat. At natanggal siya. Hold on, please. Okay, technical glitch. Naubusan ng ink. Alright, as I was saying that, okay, dati yung COLD pa siya, chronic obstructive lung disease, kasama ba yung asthma dati? Yes, kasama yung asthma. Bronchitis? Yes. Bronchiectasis? Yes. Emphysema? Yes, kasama sa lang lahat dati, no? Okay, included lahat dati yan, yung apat na sakit, no? Now, hindi, again, let me clarify, hindi ever nawala yung asthma sa listahan. Na pag eventually it was renamed to become COPD. Okay, that is chronic obstructive pulmonary disease. COPD siyang asthma kasama? Yes. Bronchitis? Yes. Kaso yung dalawa, pinagsama to become one disorder known as pulmonary, is now known as pulmonary emphysema. Uy, sino nag-share? Again, tinatawag siyang na-zoom bump ata tayo. Again, tinatawag siyang pulmonary, that's pulmonary emphysema. Alright, okay. So ulitin ko, COPD eventually was renamed to become COPD, asthma, bronchitis, saka eventually pulmonary emphysema. Naging tatlo lang sila, no? Okay. Right now, tinatawag siyang CALS. Ito yung bagong pangalan niya. Although sa Pilipinas, don't get me wrong, no? Okay. Ang ginagamit pa rin sa Pilipinas, COPD pa rin, ha? COPD, pero ang parameter nila is already pang CALS. What is CALS? Chronic Airway Limitation Syndrome. Once again, pag sinabing CALS, stands for Chronic Airway Limitation Syndrome. Okay? Ang asthma kasama, depende na. Kasi pag acute asthma, again, pag sinabing acute asthma, hold on, okay? Pag acute asthma actually is now part ng immunology, no? Which we will discuss actually. Now, part siya ng immunology. Immunology siya part, kailangan ko na space mamaya. So, part siya ng immunology problems or immunologic problems of that. That's immunology. Okay. However, pag chronic na siya, yun yung predisposing factor ng emphysema. So, again, pag acute siya, part na immune system discussion, mga hypersensitivity type 1 reaction, no? Okay. And pag chronic naman, yun yung predisposing factor ng emphysema. We'll discuss them. Now, pag bronchitis, however, pag acute is the what? Is the predisposing factor for emphysema. Again, ito yung predisposing factor ng emphysema. Pag chronic siya, guys, okay, pag chronic naman siya, actually, okay, ito yung first stage ng COPD or CALS. Ang ibang pangalan niya, either tinatawag siyang centrilobular or tinatawag na blue bloaters. So, we'll discuss in a while kung bakit siya tinawag na blue bloaters. In the meantime, okay, yung emphysema therefore, that's pulmonary emphysema, is now the second stage na tinatawag naman siyang pink puffer. Again, so we have blue bloater, the acute bronchitis, and we have pink puffer, the pulmonary emphysema. Okay, and that anyway, to move on, let's discuss now the discussion. So by the way, tatlong sakit yan. We'll talk about asthma, we'll talk about bronchitis, saka emphysema, no? By the way, lahat sila have something in common. Okay? They have something in common actually. And ang commonality ng tatlo is that they have one diagnosis. Anong diagnosis nila? Impaired gas exchange. Inuulit ko. Okay? Diagnosis ng tatlong sakit, impaired gas exchange, which means mataas yung carbon dioxide, mababa yung oxygen. Again, mataas yung CO2, mababa yung O2. Yun yung impaired gas exchange. Now with that, let's talk about asthma. Okay? So tatlong sakit tayo. Asthma, okay? May mga parameters ang ginagamit. Ang una-una, asthma. Ano yung other names ng asthma? It has several names, no? Sige, okay. Yung discussion nito, guys, magkakaiba ng other names, disorder, reversibility, or predisposing factors, involvement, pathophysiology, hallmark, tsaka other symptoms. Okay, magkakaiba sila, pero yung management, we will discuss them as one, okay? Again, okay, yung mga parameters magkakaiba, pero yung management as one siya, kasi may mga management na sabay-sabay silang ginagamit to all types of parts of COPD, I mean, no? Now with that, let's talk about asthma. Pag sinabing asthma, the other names of it, okay, are either what? Tinatawag siyang ROAD o kaya RAD. So, ano yung ROAD? Reversible. So, let you guys, ha? Okay. Pag sinabing ROAD, actually, it's reversible, obstructive, airway disease. Again, okay. Pag sinabing ROAD, reversible, obstructive, airway disease is actually ROAD. Pwede siyang tawaging RAD, RAD, reactive allergic disorder. Pwedeng ROAD, pwede ring RAD. So, anong ROAD nga? Reversible obstructive airway disease o kaya RAD, reactive allergic disorder. Na anong disorder niya therefore is a form of what? Hypersensitivity, no? Sige, mas maganda allergic muna. Okay? It's a form of allergic disorder. Okay, hypersensitivity 1, no? That's hypersensitivity type 1. So, ang discussion ng pathophysiology nito, that's hypersensitivity 1. Okay? So, ang discussion nito, ang discussion ng pathophysiology, pareho ng allergic reaction at pareho din siya ng anaphylactic shock, no? Which I'll discuss in a while. Okay? Na anong reversibility niya? Since nakalagay sa pangalan niya ROAD, na ROAD, reversible obstructive airway disease. Kaya pag nag-US ka soon, pag nakita mo sa chart ng pasyente, merong ROAD, hindi daan yun, no? It's asthma. Yun yung former na asthma. Ngayon sa Pilipinas, mas sikat pa rin yung ginagamit natin ng word na asthma. So, yun talaga yung nakilala actually, no? Okay. However, again, in other countries, ginagamit ng ROAD o kaya yung RAD. Now with that, okay? Na anong disorder siya? Allergic or hypersensitivity 1. Anong reversibility niya? It is reversible. Okay? Reversible siya actually na ang kanyang reversible, na ang kanyang predisposing factor, ilagay ko sa ilalim. Okay? So, ang reversibility niya, it is what? Considered to be reversible. Okay? Na ang predisposing factor niya, of course, we have allergens, no? Kasi ang allergic reaction siya. Allergens, allergic reaction. Before I discuss the pathophysiology, ano muna involvement niya is actually ventilation. Bakit ventilation? Pag sinabi, what is ventilation again? In and out of gases. Therefore, dito, hindi makapasok yung oxygen. How? Ito yung nangyari sa kanyang pathophysio. Again, okay? Ang predisposing, ang allergens, by the way, may dalawang klase, ha? Let me reiterate. Again, pag sinabing allergens, we have two forms of allergens. Ano yung allergens natin? May intrinsic at saka extrinsic. Matanong ko lang, okay? Nakakita na ba kayo ng mga tao na may asthma ng bata? Nung tumanda, nawala yung asthma nila. Anong allergen nila? Intrinsic. Kasi pag intrinsic is stress. Stress or anxiety. Again, pag sinabi intrinsic is stress or anxiety, ano? Okay? So may mga bata nung bata may asthma, may mga tao nung bata may asthma sila. Tumanda, nawala yung asthma. Anong allergen nila? Intrinsic. So, bakit nawala yung asthma nila, sir? Simple lang, okay? When they were young, they don't know how to cope with anxiety or stress. Again, nung bata sila, hindi sila marunong mag-cope sa anxiety or stress. Nung tumanda sila, natuto sila mag-cope. Yun, nawala yung asthma. However, yung mga may taong ganyan na may mga asthma, actually, pwedeng bumalik yung asthma nyo, ha? At any given time, okay? Kaya make sure to bring your meds. So, during the board exam, sa board exam natin, okay, baka atakihin ka ng asthma mo kasi stressful yung board exam, di ba? Kaya kailangan bring your medications, bring your inhaler. Mas maganda, dala ka ng nebulizer. Dala-dala mo sa testing area, okay? Anyway, hindi ko alam kung papayagan. So actually, so again, intrinsic anxiety or stress. Pangalawa, however, we have the extrinsic. Pag extrinsic, guys, mga external, no? So example, pwede bang food dyan? Yes. Alcoholic beverages? Yes, they're called ingestants. So, pwedeng ingestants dyan sa may extrinsic, no? Okay. Pwede rin smoke. Ganun, no? Mga sigarilyo. Okay. Ano pa? Pollen. Mga dust and so on. Inhalants naman sila. Pwede rin IV meds. Pwede natusok ka ng, na-sting ka ng bee. Okay. Natusok ka ng sea urchin. Natusok ka ng poison IV. Mga injectants or inoculants. Injectants. Last one, pwedeng pulbos, makeup, lotion that comes into contact with your skin. Ang tawag sa kanila, contactants. Those are contactants, no? Okay. However, luckily wala pang visual allergen, no? That's lucky for us. Baka nakita mo lang siya na ang pangit na, bigla ka nagka-rashes, no? Bigla ka nagka-asthma, no? Okay. Luckily wala pang ganun, no? Mga tinatawag na visual allergen. Now with that, okay, let's talk about the pathophysiology, no? So ng pathophysiology, bakit nagkaroon siya ng impaired gas exchange? Yun yung palalabasin natin ha, sa discussion, no? Kung bakit nagkaroon siya ng impaired gas exchange. Na ito yan, no? Okay. So anong cause ng allergy nga? Allergens. Nung pumasok yung allergens, guys, na by the way, yung allergens nga pala are toxins to us, no? To people like us, I mean, I have an allergen, iodine yan, no? Okay? Therefore, hindi ako kumakain ng seafoods talaga, yung crustaceans. I can eat fish, of course, obviously. Pero yung matataas yung iodine, like crustaceans, no? What are crustaceans again? Anything that turns into orange when cooked, no? Hindi tawag silang crustaceans, no? Okay? I can eat hipon, pero isang piraso. So, I opted not to. Bakit? Ikakamatay ko yun, eh. Na pagpasok ng allergens sa katawan, anong panglaban ng katawan ko? Personally, IgE. Again, allergens now, okay? Pagpasok na allergens, rather, anong panglaban ng katawan? IgE. The purpose of IgE is good. Okay, I'm telling you, it has similar pathophysiology with what? With hypersensitivity, no? So again, pumasok yung allergens. Ang panglaban ng katawan, IgE. Therefore, okay, anong goal ng IgE is that tanggalin yung allergen, no? Dalhin sa skin yung allergen. So, ulitin ko, sulat ko muna. Oops. Again, pumasok ang allergens, ang panglaban ng katawan, IgE. Now, IgE will bring the allergen to the skin. At sa skin, aatake yung tinatawag ng eosinophils. That is eosinophils. At doon tayo nagkakaroon ng rashes or urticaria, no? Kaya pag may asthma ka at may allergy ka at nagkaroon ka ng rashes, good news yun. Bakit? Lumaban yung katawan mo by sending IgE to bring it to the skin. Okay? Para nagkakaroon tayo ng rashes. Pahiran mo lang ng steroid cream, okay na. However, to some degree, to some people like yung may mga asthma, IgE can destroy their mast cells, and these mast cells are found in the lungs. Again, yung ibang taong may asthma, okay, pag may IgE sila, nasisira yung mast cells. So again, nagkakaroon tinatawag na mast cell degranulation. Again, tinatawag siyang mast cell degranulation. That, okay, pagpasok ng IgE, ang intention niya, good or bad? Good. Bakit good? Kasi magtatanggal siya ng allergen, dadalhin sa may skin, attacking eosinophils, nagkakaroon ng rashes, no? However, IgE can destroy the mast cells found in the lungs. Pag nasira yung mast cells na yan, labas ang alin? Histamine 1. Again, it will actually release histamine 1. Okay, there is two possible effects. Unang-una, nagkakaroon siya ng vasodilation. Tanong, pag nag-dilate ang blood vessel, pwede mo magkaroon ng low blood pressure? Yes. Pwede magka-shock? Yes. Kung tawagin, it's actually anaphylactic shock. Again, pag nag-dilate ang blood vessel, pwede magkaroon ng anaphylactic shock. However, it can cause bronchoconstriction. Yun na yun, no? So, pag nagkaroon siya ng bronchoconstriction, okay, ayun na, hindi makakapasok yung air, di ba? Again, pag nagkaroon siya ng bronchoconstriction, hindi makakapasok yung air. Pag di nakapasok yung air, kukulangin ng oxygen. Di ba? Taas yung carbon dioxide. Doon, nagkakaroon ng impaired gas exchange. Kaya ang asthma, part ng COPD, kasi meron siyang impaired gas exchange from the start. Okay? Anong cause ng allergy? Allergens. Okay? Pagpasok ng allergens, anong panglaban ng katawan? IgE. Na intention, good or bad? Good ang kanyang intention kasi ang gagawin niya, ilalabas niya yung allergens sa may skin, aatake eosinophils, magkakaroon ng rashes. Good yun, ha? However, to some people, like people with asthma, IgE can destroy their mast cells found in the lungs to cause the release of histamine 1. At pag may histamine 1, can cause bronchoconstriction and even vasodilation. Okay? At medyo risky ito. Bakit? Pag bronchoconstriction can cause airway problem, breathing problem. Pag may vasodilation, magkakaroon ng circulation problem. No? Okay? This will be reiterated in the topic for immunology sa discussion ng hypersensitivity. Now with that, let's talk about the manifestations of it. Nanong hallmark ng asthma, wheezing. No? Now, wheezing is a musical sound. Now, wheezing ang kanyang hallmark. Okay? Kailan malakas to? Inhalation, exhalation sa malakas, no? So, once again, wheezing is a musical sound more pronounced during exhalation. Naulit ko, ha? Okay? That wheezing is a sound, musical sound or whistling sound, parang pumipito. More pronounced during exhalation. The other symptoms, we have, syempre, dyspnea. First, we have dyspnea. That's the difficulty of breathing. Okay. Number 2, chest tightness. Talagang literal na, parang tight yung kanyang dibdib kasi nga may bronchoconstriction. Okay. That's chest tightness. And number 3 here, nagkaroon siya ng non-productive cough. This non-productive cough. Now, given the question, okay, anong cause ng kanyang non-productive cough? The answer is, yun nga, yung irritation rather, no? It's because of irritation. Kasi nagkaroon ng bronchoconstriction, na-irritate yung bronchus, nagkaroon ng non-productive cough. Kaya ang hirap nun, hindi na makahinga, ubo pa na ubo yung patient, no? Okay, so that's actually asthma. So again, okay, so review ng konti. Simple lang siya. Other names, ROD o kaya RAD. Anong disorder? Allergic or hypersensitivity. Reversibility, reversible. Allergens niya, dalawa, either intrinsic or extrinsic, no? Na pag intrinsic, stress or anxiety. Extrinsic, ingestants, inhalants, injectants or contactants. Ano yung involvement? Ventilation, which means hindi makapasok ng maayos yung air. Kasi nga, nagkaroon ng bronchoconstriction. Reverse tayo, reverse. Bakit may bronchoconstriction? Dahil may histamine 1. Bakit may histamine 1? Because of destruction of mast cells from the lungs. Why is that so? Because of destruction of IgE. Okay, and because of what? The presence of allergens. Okay, yun yung pathophysiology ng asthma. Therefore, ano yung kanyang hallmark nga? Wheezing. Again, yung hallmark, remember, isang symptom na hindi pwedeng mawala. Now, other symptoms, we have dyspnea, chest tightness, at saka non-productive cough because of irritation. Okay, that is asthma for us. That's a topic for asthma. In the meantime, let's discuss the next one here, which is actually bronchitis. So, tapos tayo sa isa ha. Yung management will be discussed as a whole because I told you there are similarities in management. Pag bronchitis naman, refers to inflammation of the bronchioles, which impairs airflow. How? Okay, kala natin just because of inflammation, di makapasok yung air, no? But actually, there's a deeper problem in bronchitis, no? Now, dalawang klase yan, may acute at saka chronic. Now, with that, okay, anong other names na? Pwedeng tawaging panlobular stage, which I'll explain in a while. Okay, can be called the panlobular stage. Panlobular, okay, ate siyang blue bloaters, no? As to whether why, can be explained in a while, no? Hopefully, you'll get it, no? Okay, blue bloaters. At since itis siya, ano yung kanyang disorder? It's an inflammatory disorder. So, ang disorder niya is an inflammatory siya. Oops. It's an inflammatory disorder, no? Okay. However, I told you it's deeper. It's a deeper problem, no? There's a deeper problem here. Okay. Mas malalim na explanation bakit siya nagiging part ng COPD. Now, by the way, okay, anong reversibility niya? Depende. Pag acute is considered to be reversible. Kapag chronic, said to be what? Irreversible. Now, okay, ang predisposing factor ng acute madalas is actually what? Upper respiratory tract infections. Again, okay, lower pala, sorry, lower. Ang cause ng acute actually is lower respiratory tract infections. And let me remind you guys, okay, that yung COVID-19 na to, isang komplikasyon niya bronchitis, no? Kasi nga, okay, lumalaban yung katawan eh. Kaya actually, now, in fact, ang anong unique feature ng COVID-19, sabay nagkakaroon ng upper tsaka lower respiratory tract infection. That's a very rare, in fact, yun lang alam kong sakit, no? Nasabay may upper ka na, may tonsillitis ka na, meron ka ng pharyngitis, etc. Meron ka pang, marami ka pang phlegm, no? Okay, so ang common cause ng acute is lower respiratory tract infection. Pag chronic kasi, ang cause naman madalas cigarette smoking talaga or pollutants, no? The cigarette smoking, may government warning, di ba? Cigarette smoking is still best for your babies. Mali. It's dangerous to your health. Okay? Ayun yung ating actually reversibility and predisposing factors. Now, anong involvement niya? Is still ventilation. That would mean, oops, mag-e-echo to. So, ulitin ko Yeah. As I was saying, that involvement actually, okay, is ventilation. That would mean hindi makapasok yung air pa din, no? At that. Anyway, to move on, let's discuss now. So, ayun yung ating parameters, other names, panlobular, okay, blue bloaters. Disorder niya is inflammatory kasi itis siya, di ba? But again, there's a deeper problem there. Reversibility, acute is reversible, chronic is reversible. Predisposing factor ng acute, lower respiratory tract infections, and pag chronic naman madalas cigarette smoking kasama yung pollution syempre, no? Pero again, mas kakaiba pa rin yung cigarette smoking kasi talagang ini-intake mo tinetake mo yung sigarilyo sa katawan mo, no? Okay, that is cigarette smoking actually. Now, in which case, to move on, let's talk about the pathophysiology. Before that, okay, before I discuss pathophysiology, let me explain to you one defense mechanism, no? Okay, isang physiology ng ating lungs kung paano ano yung defense ng katawan against foreign objects, no? Let me talk to you about mucociliary transport system. So that's mucociliary transport system, no? Okay, let me discuss to you this. Ang tawag sa kanya mucociliary transport system. Now, MCTS is a defense against foreign bodies, no? Once again, okay? Pag sinabing MCT is mucociliary transport system, is a defense against foreign bodies. Now, dalawang klaseng foreign bodies, may macro at saka micro. Okay? Example, ang dust, ano siya? Macro. Smoke, macro. Pollen, macro. Basta kita pa ng mata, macro ang tawag doon. Kasi pag micro, yan na yung mga virus, bacteria, fungus, lahat ng pathogens, micro. So, ulitin ko ha, okay? Kahit maliit yung dust, macro pa rin siya. Basta kita pa ng mata, macro ang tawag sa kanya. So, again, okay? Pag sinabing MCTS, mucociliary transport system, ano nga siya? Defense against foreign bodies. These are defense against foreign bodies, no? Dalawang klaseng dalawang din depensa niya, macro tsaka micro. Na para madaling ma-recall, tatlong sito, no? CCC. Okay, first actually is cilia. Cilia, so first defense, cilia or the coarse hairs. Okay? Nga lang, ang limitation ng cilia, ang kaya niya i-trap macro lamang, no? Now, okay? So nakikita yan sa ilong natin actually, yung mga ciliary hairs or the coarse hairs found in our nose are called the ciliary bodies. Kaya ang kaya lang i-trap niya, mga macro lang, no? Mga pollen, mga dust, mga smoke, and so on, no? Okay? Kaya matanong ko lang, saan mas maganda mag-inhale? Nose ba or mouth? The answer is nose. Alam mo kung bakit? Okay? Kung madumi man yung hangin na ini-inhale mo, itatrap siya ng cilia. Naulit ko okay? Kung madumi yung air na ini-inhale mo, itatrap siya ng cilia. Kaya naman may nabubuong something sa may ilong, no? Okay? Anong form nun kung tawagin ay kulangot, no? Okay? Ayan. Kaya nabubuo yan actually. That means pag lagi ka may kulangot, that means madumi yung ini-inhale mong hangin, no? Share ko lang, ha? Okay? Kung feeling mong Pilipinas, Manila is very polluted, try to go to China, no? Okay? In Beijing, in China, we were there around basta few years ago, not beyond 5 years ago, no? Okay? I was in China with my family actually. Araw-araw na lang, grabe, no? Okay? Yung kung may puti kang part ng damit, nagiging gray siya sa hapon, no? Pangalawa, okay, is that yung sa hapon talagang daming kulangot, no? Okay? Yan sa talagang pag ganun mo talaga, alam mo yung buo-buo, pwede mo ipunin talaga, no? At that, no? Kaya nga, kailangan tanggalin yan. By the way nga pala, okay, pag gising sa umaga, anong unang kailangan tanggalin? Kulangot ba or muta? Ulitin kong tanong, okay, pag nagising ka sa umaga, anong unang kailangan tanggalin? Kulangot o muta? Ang sagot ay kulangot. Because priority is airway. Okay, airway yan. Kaya kailangan kulangot muna bago muta. Anyway, cilia or coarse hairs, ang kaya niyang tanggalin macro lamang, no? Mga malalaki lang. Okay? However, paano kung bacteria, sir? Nakapasok ang bacteria sa lungs. For example, anong lalaban na cells na? Second defense are actually cells. Now, cells are the following. First, the phagocytes, na maraming klase ito, hindi ko na-specify kung ano yung mga phagocytes. Basta ang goal ng phagocytes to kill the pathogens, no? Again, ang goal ng phagocytes to kill the pathogens. Yun talagang goal niya actually, no? Okay? Now, however, pag namatay yung pathogens, what will happen next? Ano mangyayari dyan? Di, maiipon sila. Sige, okay? Kasi ang pangalawa dyan, goblet. Pakitandaan, ha? Ulitin ko, okay? Sige, naka-inhale ka ng smoke, ng dust. Anong ginawa ng cilia? Trinap niya sa ilong. Okay? Kaya nagbuo yung kulangot, at least ang kaya niyang itrap lang macro. Kaya it's more ideal rather, to inhale on the nose. Kasi kung madumi man yung hangin na kinukuha mo, itatrap siya ng ciliary bodies or cilia. On the other hand, okay, we have here, paano pag bacteria na inhale mo? Hindi itatrap ng cilia kasi micro yun eh. Diretso ng lungs. Paano kung virus? Diretso ng lungs. Anong una-una? Phagocytes. Okay? That's unang-unang atake are phagocytes. Anong purpose nila? To kill the pathogens na coupled with goblet cells, they combine together. Sige, discuss natin, ha? Okay? Dumating yung bacteria or virus. Again, dumating yung bacteria or virus. Teka lang, ha? As I was saying, okay? So again, oops. Mali. As I was saying, I can say anything. Teka lang, hindi ko mahanap. Alright, okay. Ito na. Alright, dumating yung bacteria or virus, no? Anong ginawa ng phagocytes? Umatake yung phagocytes. Na pag-atake niya, anong purpose niya? To destroy the pathogen. Yun nga lang, okay? Ang sinasabi ng books natin that these phagocytes are suicidal. Which means, umatake yung phagocytes, yung pathogen, inatake ng, ano ba yan? Dumating yung pathogens, inatake ng phagocytes. Okay? Anong purpose niya? To kill the pathogen, kaso pati siya mamamatay na. At pag namatay siya, ang tawag sa kanya dead cells, na. Again, pag namatay yung phagocytes with the pathogen, dead cells. Ano mangyayari ngayon doon? Okay? Yung dead cells na yan will be collected by the secretions produced by the goblet cells. Again, yung dead cells will be collected by the secretions produced by the goblet cells. Kaya nga pag nagsama yan, sige, again, ha? Okay, dumating yung pathogen, inatake ng phagocytes. Patay yung pathogens, pati yung phagocytes. Anong tawag sa kanya ngayon? Dead cells, no? The dead cells now will be collected by the goblet cells. Anong purpose ng goblet cells? To produce secretions. Okay, secretions actually. Now, how will the goblet cells collect it? By producing secretions. One more time, from the start. Okay, dumating yung pathogen, sige, bacteria or virus na lang. Dumating yung virus, umatake yung phagocytes. Papatayin ba niya? Yes. Pati siya, however, patay. Nung patay na siya, ang tawag sa kanya, obviously, dead cell, no? What will happen to the dead cells then? The dead cells now will be collected by the secretions produced by the goblet cells. Na question. Okay, anong tawag doon ngayon? Yung secretion ng may dead cells, anong tawag doon? Phlegm. Kaya we produce phlegm. The more serious the infection is, the more phlegm you'll have. That means lumalaban yung katawan. Kaya yung mga taong may COVID-19, sobrang daming phlegm talaga kasi nga sobrang dami ng pagbilis. Sobrang bilis ng pagdami ng SARS-CoV-2, yung virus ng COVID-19. Okay? So one more time, dumating yung dumating yung pathogens. Inatake ng phagocytes. Patay ba yung pathogens? Yes. Pati yung phagocytes patay. Anong tawag sa kanya? Dead cells. Nung patay na, magstay sa lungs. So, anong gagawin ng goblet cells to produce secretions para i-bind niya. Para tanggalin yung pag mubukap, tanggal ngayon yung phlegm kasama na yung dead cells. No? Kaya nga pag mas marami kang phlegm, ibig sabihin, mas matindi yung infection. Okay? Then, paano magtanggal ngayon ng ng phlegm? Of course, number 3 there is actually cough. Again, paano magtanggal? Actually is, cough will remove everything, no? So, yun yung 3 C's natin, okay? Cilia, cells, cough. Kaya part of MCT as mucociliary transport system. Now, what happens in bronchitis? Ang problema sa bronchitis, ito, kaya smoke. Okay? Kauubo, nagkaroon ng ito. Problema niya is that dumami yung goblet cells, no? So, again, okay? Ang main problem talaga dyan is pagdami ng goblet cells. Especially for smokers, kasi nga, ang cigarette smoke talaga ini-induce mo, no? Pinapasok mo sa katawan mo. Sir, safe ba yung yung vape, e-cigarette? Okay, hindi pa alam kasi bago pa lang siya, no? Pag tumagal, malalaman yung ill effects. Ngayon, isang ill effect ng vape because it's actually a chemical, nagkakaroon ng lung cancer yung mga nagve-vape, no? Okay? So hindi rin siya magandang alternative. Wala kang asthma, nagkaroon ka naman ng lung cancer, no? Tsaka still, yung kanyang nicotine andun pa rin, no? Okay? Pathophysiology, bakit siya nagkaroon ng impaired gas exchange? Bakit may ventilation problem? Maraming goblet cells. Logically speaking, pag maraming goblet cells, dadami ang secretions. Again, pag maraming goblet cells, dadami ang secretions. Pag maraming secretions, ito yung problema ngayon. Okay? Can cause pulmonary congestion. Again, so explain natin dito kung bakit siya blue bloater. Wag kukurap, guys. This is highly important for our topic, no? Ulitin ko lang, okay? Nung dumami ang goblet cells, dumami ang secretions. Pag dami ng secretions, what happens next? Is actually nagkaka-pulmonary congestion. Sulat ko lang, ha? Now, nung nagkaroon siya ng pulmonary congestion, ano naapektuhan sa kanya? Again, nagkaroon ng pulmonary congestion. Okay? Ano naapektuhan sa kanya? Dalawa. First is the blood flow. Airflow muna, okay? First is the airflow. Pangalawa, naapektuhan yung blood flow. Naulit ko yan, ha? Okay? So, nagkaroon siya ng pulmonary congestion leading to airflow problem tsaka blood flow problem. Unahin ko yung airflow. Siyempre, okay? Since barado siya. By the way, guys, anong marami sa kanya? Secretions, no? So, bukod sa inflammation, di na nahirapan ng pumasok yung air, nagkaroon pa ng phlegm. Before I continue further, let me show you a visual para ma-appreciate mo, no? Okay? Ito nangyari, on the left part is the normal bronchi. Papansinin mo, manipis yung gilid. Again, manipis yung gilid niya. Maluwag yung gitna. Alright? Okay? Na wala pang harang. Sa bronchitis, kumapal yung gilid. Bakit makapal yung gilid nga? Kasi maraming goblet cells. At isa pa, nagproduce ng maraming secretions. Kaya nabarahan yung gitna, hindi makapasok yung air. Kaya may ventilation problem actually. So yung problema, kaya may airflow problem. Kasi nabarahan yung gitna. Now, okay? Airflow problem will lead to what? Hypoxia, no? At pag nagkaroon siya ng hypoxia, decrease ang oxygen, tataas yung carbon dioxide, nagkakaroon ng impaired gas exchange. Yun yung problem doon actually. So ulitin ko, ha. Okay? So again, dumami ang goblet cells, dumami ang secretions. Nagkaroon ng pulmonary congestion. First, nagka-airflow problem. Pangalawa, ay leading to what? Hypoxia. At pag nagkaroon siya ng hypoxia, nagkakaroon siya ng impaired gas exchange. However, nagkakaroon ng blood flow problem, no? Leading to possible core pulmonal. Again, nagkakaroon ng airflow problem leading to possible core pulmonal. Na ano yung core pulmonal kung tawagin, guys? Or core pulmonale or core pulmonal, ha? Okay. Pag sinabing core, mali pa spelling ko. Again, tinatawag siyang core pulmonal or core pulmonale. Pag sinabing core pulmonal is actually what? A form of right-sided heart failure secondary to pulmonary hypertension. So heart failure talaga siya. Again, sa form secondary, let's say right-sided heart failure secondary to pulmonary hypertension. Again, secondary to pulmonary hypertension. Explain natin into one topic, no? At explain ko sa inyo kung bakit tinatawag siyang blue bloater stage. Let me begin by discussing it. Now, on your screen, okay? So, ito yun, no? Na again, nagka-airflow problem tsaka blood flow problem. Kailangan ko ng diagram and review. Hindi tinatawag na cardiopulmonary circulation. Now, okay? Ito yung tinatawag natin na cardiopulmonary circulation, ha? Now, let me make it bigger. Okay. So, blood from our body, sige, ma-review to sa cardio. Blood from our body goes to our heart by the vena cava, or vena cava, superior, tsaka inferior. Again, blood will go here to our heart with vena cava, superior, tsaka inferior. From then on, pag pumasok yung blood dyan, actually, okay, pasok sa may right atrium. Review ng konti, ha? Okay. Blood from our body goes to the heart by the vena cava, inferior, superior, inferior. Pasok sa right atrium. From then, it will pass through the tinatawag na valve, tricuspid valve, no? Ito yan, okay? The tricuspid valve actually is here, okay? Pasok sa may right ventricle. From right ventricle, pasok sa pulmonary arteries. I told you, ang laman niya deoxygenated to reach the lungs. For what purpose? Oxygenation purposes. Stop muna tayo dun, no? Yun lang kailangan for topic, you know? Okay? Pag nag-cardio tayo, discuss natin ang buo yun. So, once again, blood from our body goes to our heart by the vena cava, or vena cava. Okay? From then, it will go to where? The right atrium, and then right ventricle, passing through the pulmonary arteries, going to our lungs. For what purpose? Oxygenation. Yun yung purpose actually ng yun yung ikot niya, no? Okay. Ngayon, nangyari is that, dumami yung goblet cells. Review ng konti, guys. Okay. Dali lang, inom lang ako sandali. Now, let me go back to this discussion. So, again, okay, review before I continue. So, again, yun nangyari. So, what happened again in bronchitis is that maraming goblet cells. Pag dami ng goblet cells, dumami ang secretions, leading to pulmonary congestion. So, eto na, balikan ko yung visuals, no? Okay. Hugutin ko dito yung discussion. Actually, is that marami siyang secretion ngayon, no? Ang daming phlegm. Okay. Maraming secretion sa loob ng lungs ngayon, actually. Nung maraming secretion dyan, di makapasok yung air. Kaya I told you, meron siyang airflow problem, no? Kasi hindi makapasok yung air. Thus, therefore, okay, magkakaroon siya ng hypoxia. Now, what's the earliest sign of hypoxia actually is? Restlessness or irritability, no? Okay, again, the first sign, okay, our first manifestation hypoxia is restlessness. Ang late sign niya, guys, cyanosis. Okay? Siyempre, kasama na yung mga, mga altered LOC and so on and so forth, no? Pero yung noticeable sign mo, magkakaroon siya ng cyanosis. One more time, ha? Okay? Dahil puno ng plema yung lungs, hindi makapasok yung air. Nung hindi makapasok yung air, nagkaroon siya ng hypoxia. Okay? At pag may hypoxia, the earliest manifestation is restlessness. Ang late manifestation, guys, is what? Is cyanosis, no? Sige, sulat ko ng pareho para may reference tayo, no? Okay? So again, the earliest manifestation is actually restlessness. Pwedeng irritability yan. That's restlessness. Oops. Again, okay? Sulat ko pa na mas maayos. Okay? Ang earliest manifestation, this earliest is restlessness. Restlessness. Ang late na niyan actually is what? Okay? Cyanosis na. Earliest restlessness, late is cyanosis. Yun yung implication niya, no? Okay? Na bukod sa airflow, however, may problema sa blood flow. Sige, therefore, okay? Pag sinabing blood flow, guys, blood from here dapat, from the heart, di ba? Pasok dapat ng lungs. Ang problema nga, okay, congested yung lungs, so hindi makapasok yung blood from here. May ipon yung blood sa my pulmonary arteries. Na pag yung pressure niya nag-more than 25 millimeters of mercury, ang tawag sa kanya ng pulmonary hypertension. Ulitin ko yan, ha? Okay. So again, unang-una nagkaroon siya ng hypoxia. Kasi hindi makapasok yung air. Kaya I told you may airflow problem. Nung hindi makapasok yung nung nagka-hypoxia siya, earliest manifestation, restlessness. Ang late natin, cyanosis. Na bukod sa airflow, may problema saan? Sa blood flow yung patient. Therefore, okay, pag may blood flow problem, I mean is that, okay, hindi makapasok yung blood from the heart to the lungs. Therefore, maiipon yung blood saan? Sa may pulmonary arteries. Pag naipon yung blood sa pulmonary arteries at tumaas yung pressure na more than 25, it's called pulmonary hypertension. With that, pag nagka-pulmonary hypertension, mag-start mag-backflow yung blood saan? Sa may right ventricle and then right atrium, mapupuno ng blood yung dalawang area. Okay? Ayun, meron ka na ngayong right-sided heart failure na kung tawagin core pulmonal. Again, meron ka ng right-sided heart failure, kung tawagin core pulmonal. Okay? And that therefore, so tuloy natin ha. So, alam mo na yung complication. Yung na-mention ko kanina, core pulmonal is right-sided heart failure secondary to pulmonary hypertension. Now, with that, okay, pag nangyari yan, therefore, backflow pa ulit yung blood, no? So, from the lungs, nag-backflow yung blood sa may pulmonary arteries, then backflow sa may heart, kaya nagkaroon ng core pulmonal. Now, pag nagka-core pulmonal, yung blood here na puno, yung blood from the vena cava hindi na makakapasok, no? So, backflow sa entire body. Again, the blood will backflow in the entire body. Pag nag-backflow yung blood sa entire body, tataas yung hydrostatic pressure. Pag tumaas yung hydrostatic pressure, magkakaroon siya ngayon ng edema or anasarca. Okay, the client will suffer anasarca or edema. Na sige, kumpletuhin natin ha. Okay, may anasarca or edema, actually generalized edema. Sige, okay. Mali pa spelling ko. Ayusin ko lang. Nakakahiya. Okay. Again, baka dahil nag-backflow ang blood sa entire body, nagkakaroon siya ng anasarca. Okay. Anasarca actually is generalized edema. Kumpletuhin natin. Question. Unang-una, nagka-airflow problem. Anong late sign ng hypoxia? Cyanosis. Therefore, anong kulay ng cyanotic? Blue siya. Bukod sa airflow, may blood flow problem, right? Okay, nagka-backflow, nagkaroon siya ng generalized edema. Anasarca yung tawag doon. Okay, ano nasarca nga ulit? Question, pag may anasarca, mukha ba siyang mataba? Yes. Mukha ba siyang bloated? Yes. Kaya nga meron siyang blue bloater stage. Mukha siyang mataba kasi anasarca. Kaya nga blue, why blue? Cyanosis. Bakit bloater? Anasarca. So, blue bloater stage is actually bronchitis or chronic bronchitis. Okay? Yun na siya actually, no, in discussion ng chronic bronchitis. Again, bakit blue? Because of cyanosis. Bakit bloater? Because of anasarca or edema. Okay? Yun yung ating blue bloater stage or the chronic bronchitis. Now, therefore, ano yung kanyang hallmark? Question, marami bang plema? Yes, kaya meron siyang productive cough. Inulit ko, okay? Since marami siyang phlegm, nagkakaroon siya ng tinatawag na productive cough. Sulat ko na that the hallmark here is actually productive cough because of too much phlegm nga. Kasi sobrang dahak na, this productive cough. With that, okay, ano yung other symptoms niya? Coughed as the mnemonics. Na medyo madami siya actually. Coughed na, parang hindi rin malayo-layo ng konti. Okay, coughed as the mnemonic. Unang-una is cyanosis. Again, other symptoms ng bronchitis, unang-una cyanosis yan. Cyanosis. Okay. Ano pa? Obvious, rales, and rhonchi. So, pag narinig mo yung dalawang yan, actually, ibig sabihin, marami siyang phlegm talaga, no? Obvious, rales, and rhonchi. Ano yung pa? Unusual irritability. Remember? First sign ng hypoxia, restlessness, or irritability, no? Okay. That's unusual irritability. Ano yung G? Generalized edema. Anasarca. Kaya nga siya bloater, remember? Okay. This generalized edema. Ano pa? We have high CO2 level. Hindi makatanggal ng CO2. Kaya nga meron siyang impaired gas exchange which may lead to possible what? Okay, respiratory acidosis. Remember, the more CO2, the more carbonic acid. Okay, nagkakaroon siya ng respiratory acidosis. Na ano yung E stands for? Okay, E stands for exertional dyspnea. Exertional dyspnea. Ano yung okay. Pag sinabing dyspnea, difficulty of breathing, no? Pag sinabing exertional dyspnea, konting galaw ng pasyente hindi na siya makahinga. Yung konting effort, yung kakain lang siya, susubo lang, hindi na makahinga, magsasalita lang, kinakapos na, yun yung exertional dyspnea. And last, distended neck veins or distended jugular veins. Because again of what? Right-sided heart failure. Distended jugular veins. Okay, these are the symptoms of chronic bronchitis. With that, let's talk about the last part. Okay, last part ng COPD known as the pulmonary emphysema or the pink puffers or the tinatawag na panlobular stage. Parang mali na sulat ko kanina. Okay, ay mali nga, sorry. Okay, better late than never. Hindi yan panlobular, dapat yan ay centrilobular. Sorry sa mga nagsusulat, no? Better late than never. Okay, centrilobular stage. So last one here. Okay, last part ng ating COPD before we discuss the management, emphysema. Okay, emphysema has other names. Unang-una, tatlong pangalan niya ngayon, no? Yung isa siguro alam mo na. Other names are the following. Unang-una, panlobular. Ito yung panlobular, guys. Sorry, Ito yung panlobular stage. Okay, tinatawag siyang pink puffers. Pink puffers. Okay, pinakamasaklap niyang pangalan, terminal lungs. I'm telling you, when you hear the word terminal, laging bad news yun, no? Kasi pag terminal, katapusan na, no? Okay, wala nang kasunod. At pag terminal, susunduin na siya. Now, okay, anong disorder ng sakit? What type of disorder it is? It's actually an autoimmune disorder. Again, it's an autoimmune disorder such that, okay, since autoimmune, kalaban mo sarili mong katawan, no? At that, okay, ano yung kanyang reversibility? Since terminal lungs ang tawag sa kanya, it's an irreversible condition. Again, it's an irreversible condition, and that, okay, anong predisposing factor niya? Aha, AHA, no? Predisposing factors dapat yan, okay? AHA, unang-una, age. Okay, ang age, guys, 60 and above. Okay, pangalawa, heredity or genetics. Kaya no common, mga white people na white men. Again, aha, okay, the heredity is actually gender, no? Okay, anong age? Anong age niya? 60 and above. Pangalawa is hereditary siya, heredity. Common to white men. Okay, pangatlo, asthma and bronchitis. Na na-mention ko kanina, no? That is asthma and bronchitis. These are the predisposing factors of emphysema, no? Terminal lungs. Ano involvement niya, guys? This time, sige, okay. Ang problema this time is that nakapasok yung air. So, walang problema sa ventilation. Ang problema, ayaw mag-exchange yung gases, no? So, ang tawag sa kanya, problem ano what? Alveolar diffusion. So, the problem here is actually alveolar diffusion. Sulat ko lang, this alveolar diffusion, okay, is a problem for emphysema, no? So, let's talk about it. Okay, bakit naging pink puffer siya, and bakit siya nagkaroon ng impaired gas exchange? Okay, ito yung problem niya actually with the pathophysiologic basis, no? I told you earlier, so itong pinakasimpleng pathophysio, yun nga lang, ito yung pinakaseryoso, no? Okay, the unfortunate thing, the exact cause is unknown. At alam mo yan, alam mo to, no? Okay, lahat ng sakit na unknown ang cause, hindi alam kung paano i-treat, no? So, treatable, but not curable. One more time, they are treatable, but not curable. So with that, ito yung discussion, ha? Okay, now ang problema is that, sige, I told you earlier, pag nag-inflate yung alveoli, tingnan mo na, pag pumasok ang oxygen rudder, sige, pakita ko lang yung ating physiology kanina, very important yan, eh. Okay, pag pumasok yung oxygen, ano nga ilalabas ng katawan na enzyme? Elastase, responsible for deflation. Pag ang meron naman siya is carbon dioxide, ano yung lalabas? Anti-elastase, responsible for deflation. Now guys, simpleng-simple lang to. For unknown reason, however, I give you the predisposing factors. For unknown reason, wala siyang anti-elastase. Again, okay? So, ang start ng pathophysio natin, wala siyang anti-elastase. No? So, isulat ko, ha? Okay? There's no anti-elastase. So, therefore, anong role ng anti-elastase? To deflate the alveoli. Kung wala siyang anti-elastase, what happens is that wala siyang deflation properties, no? Ayaw niya mag-deflate, walang recoil kung tawagin, no? Wala siyang deflation properties. Therefore, walang deflation, simple lang. Kung walang deflation, nagkakaroon ng over-inflation of the alveoli, no? Ang ibang books ang sabi over-distension. Pareho lang yan. Over-inflation of the alveoli. Ngayon, itong problema, okay? Pag, therefore, sige, with that, sabihin ko agad yung hallmark, ha, para maihugot natin from this topic, no? Okay? So again, walang anti-elastase. Ayaw niyang mag-deflate. Nung ayaw mag-deflate, nagka-overdilation of, overinflation, overdilation of alveoli. Therefore, nag-inhale yung pasyente, mag-inflate ba? Yes. Deflate? No. Kasi wala siyang anti-elastase. Once again, okay? Nag-inhale yung patient, mag-inflate ba? Yes. Deflate? No. Inhale ulit. Inflate? Yes. Deflate? No. Inhale ulit. Inflate? Yes. Deflate? No. Hanggang mag-full inflate yung alveoli. Pag naka-fully inflate yung alveoli ngayon, okay, lalaki yung mga alveoli, di ba? Pag laki ng mga alveoli, what happens next? Lalaki yung lungs. Pag lumaki yung lungs, lalaki yung diameter ng chest. At anong tawag doon? Barrel chest. Yun yung hallmark ng emphysema, barrel chest or the barrel-shaped chest. And the reason for that is the overinflation of the alveoli. So, pwedeng tawagin barrel chest lang or barrel-shaped chest. Okay, laki ng kanyang talagang ang laki ng anterior posterior diameter ng kanyang chest kasi naka-overinflate yung alveoli. With that, therefore, okay, so ngayon hindi ngayon makakatanggal ng carbon dioxide. Alright, okay, so therefore tataas ang CO2, di ba? Tataas ang CO2 level, leading now to hypoxia. Sige, teka lang, ha. Okay, again, as I was saying that pag therefore bagsak yung kanyang mataas yung CO2 niya, di ba? Pag mataas yung CO2, the body will compensate. How? Okay, by hyperventilation. Again, so magkakaroon ng hyperventilation yung pasyente. Balikan ko yan mamaya. Okay. Bukod dyan, bagsak yung O2 ng katawan, di ba? Pag bagsak yung O2 ng katawan, the kidneys will be stimulated. Okay, this will be related na to our kidney topic or renal topic, no? Pinapaliwanag ko ngayon bakit siya pink puffers, no? So once again, from the start, okay, nawala yung anti-elastase. Walang deflation. Nagkaroon nga ng overinflation of the alveoli, increasing carbon dioxide, leading to hyperventilation as a way of compensation, no? Okay? Now, also, bagsak yung kanyang oxygen, no? Therefore, feel ng katawan kulang ng blood, no? So, this will stimulate the kidneys to actually what? Cause erythropoiesis. Magkakaroon ng erythropoiesis, dadami ngayon, which means dadami ang production ng RBC, no? Ang primary organ yan, kidneys, by stimulating the what? The renal erythropoietic factor, yung topic natin sa may renal condition. So again, kulang ng O2, nagkaroon siya ng erythropoiesis. Nung nagkaroon ng erythropoiesis, what comes next? Therefore, dadami yung RBC. And that, therefore, pag maraming RBC, ito na nga mangyari dyan. So, i-discuss natin ha. Okay. Maraming RBC, magkakaroon siya ng pinkish skin color. Kaya naman siya, pink puffer, no? Okay. Pinkish skin color, no? So, bakit puffer? Sige, question. Okay. Ano nangyari nga? Sige, from the start ha, gusto kong i-amplify na maayos. Sige, ibaon natin ng gusto. Okay. Wala siyang anti-elastase. Nawala yung deflation properties. Tuloy nagkaroon ng overinflation of the alveoli, leading to what? Too much carbon dioxide, and the body will compensate by hyperventilation. Listen guys, okay? Ang layman's term, sige, ang hyperventilation, actually, parang siyang hinihingal, no? Yun talaga. Tanong, anong layman's term na hinihingal? Pag nasa US ka o sa abroad, hinihingal ka, anong tanong sa'yo? Why are you hingalizing? Ganun ba? Yung may tanong, why are you hingalizing? Or, why are you having hyperventilation? Hindi naman ganun, hindi hyperventilation yung term. Anong term nila? Puffing, no? So, pag hinihingal ka, ang tawag sa'yo, puffer. Puffing rather, you're puffing. Why are you puffing? Ganun sila, no? Meaning, hinihingal ka. Therefore, yung hyperventilation is the puffer, di ba? So, ngayon, okay, puffer yan. However, anong kulay niya nga ulit? Pink siya because of too much RBC. Bakit ganoon? Kasi nung nagka-hypoxia siya, nag-stimulate yung kidneys to what? To actually engage in erythropoiesis. Dumami yung RBC. Ang taong maraming RBC, pinkish ang skin color. Kaya tinawag siyang pink puffer. Bakit pink? Because of too much RBC. Bakit puffer? Because of compensation, because of hyperventilation. Okay? Yun yung blue bloater tsaka pink puffer stage. Kanina sa bronchitis, bakit blue? Cyanosis. Bakit puffer? Because of anasarca. Yun yung discussion yan. So, tapos tayo. Okay? Sa emphysema as a topic. So, therefore, ano yung kanyang hallmark nga? Barrel-shaped chest. So, other symptoms, okay, are the following. Anong dalawa na mention ko na, di ba? Unang-una, again, meron siyang pinkish skin color. Pinkish skin color. Now, pangalawa, okay, meron siyang syempre meron siyang hyperventilation. Kaya nga puffer, remember? Client will suffer hyperventilation. That's hyperventilation, okay? Hyperventilation, okay? Number 3 here is that magkakaroon siya ng still non-productive cough, no? So far sa tatlo, ang productive lang talaga is yung bronchitis, no? Non-productive cough, yung mga symptoms natin, okay, for this emphysema thing, no? So we're done discussing the disorders, the 3 disorders. We had asthma, bronchitis, and pulmonary emphysema. With that, okay, pakita ko lang yung mga common signs and symptoms ng lahat, no? So lahat sila merong over-coughing. Yun nga lang, okay, yung dalawa non-productive, yung isa productive. Also have laborious breathing. Yun yung tinatawag na exertional dyspnea. Yung konting exert ng effort, pagod agad. Okay? In fact, ano yung manifestation ng laborious breathing is the use of accessory muscle for breathing. Na imbis na diaphragm gamitin niya, ginagamit niya balikat. It's called laborious breathing. Also, dyspnea, that's global to all. Feeling of breathlessness, kinakapos, anorexia, tiredness or fatigue, increased RR, greater breathing depth, unused irritability, and excessive weight loss. Lahat yan, common signs and symptoms ng lahat ng part ng COPD, asthma, bronchitis, and emphysema. Now with that, let's talk about now the management of all, no? Okay? So yung management ngayon will be discussed as one. However, okay, minsan isang sakit lang siya kailangan, no? But again, we involve them as one kasi ang daming management na lahat ginagamit naman, like yung oxygenation, no? Or oxygen therapy. So una, okay, let's start discussing first the bronchodilators, no? So obviously, saan ginagamit ito? Malamang yung ginagamit lang yan sa may asthma, no? Kasi ang asthma merong bronchoconstriction. However, okay, let me begin by telling you that the only bronchodilator in the body is really epinephrine. Inuulit ko ha, okay? The only bronchodilator is actually epinephrine. Sir, bakit marami nakalistang gamot? In fact, may dalawang sample tayo dyan, no? Sa may screen natin, okay? Yung tinatawag na B2AA, tas beta-2 adrenergic agonists, at saka xanthine derivatives. Ba't may ganyan? So, paliwanag ko muna. I-explain ko tong dalawang to bago ko ipaliwanag kung bakit ko sinabi that the only bronchodilator is epinephrine. Na unang-una, B2AA is beta-2 adrenergic agonists. Example are the ones ending with ol. Ano yung ol? Salbutamol. That's salbutamol at saka albuterol. Again, salbutamol and albuterol are examples of this B2AAs, no? Anong route niya? Via inhaler. Now guys, let me clarify May oral route yan, no? May oral route sila, pero actually, given siya via inhaler. Okay? At pag inhaler siya, take note that ang kulay ng kanyang container is blue container. Yun nasa screen. Okay? Yan yung color niya, no? Yun yung color ng inhaler niya, actually nasa screen kulay blue. By the way, kanya-kanyang kulay, kanya-kanyang laman, hindi trip-trip lang na favorite color, ha. So again, okay, so examples of B2AAs, salbutamol and albuterol. Anong route niya? Via inhaler. Advantage niya, since via inhaler, fast acting siya. So ideal during acute attack kasi fast acting siya. Ang problema sa gamot ito, pag isang gamot mabilis gumana, mabilis mawala yung effect. Niulit ko okay? Pag isang gamot mabilis gumana, mabilis din mawala yung effect na nagiging advantage ng pangalawa. Xanthine derivatives na. Common dyan, mga fill-in naman, no? Like aminophylline. Tas aminophylline at saka theophylline. Again, aminophylline and theophylline are common examples of these drugs. Na route niya pwedeng oral, no? Pwedeng oral, pwedeng EIV or parenteral route. Yun nga lang, mas mabilis pa rin yung inhaler kasi pag puff mo few seconds, okay na. Okay? Ang advantage naman nito is that long half-life niya. So, ang kanyang half-life, lalo na pag na-maintain, long half-life siya, okay? Pag na-maintain yung therapeutic level niya, no? Anong therapeutic level ng gamot is actually 10 to 20 micrograms. Check that, sorry. Again, okay? Ang normal therapeutic level is 10 to 20 micrograms per DL, no? mcg per DL, yung normal level ng xanthine. Pag na-maintain yan, okay, halos walang attack yung patient, no? Yun nga lang, side effects are still the same. By the way, special note, no? When giving xanthine derivatives, no? Avoid caffeine. Avoid caffeine. Bakit? Caffeine can cause false elevated result. Kasi nga, hinahanap sa blood yung level ng xanthine. Anong normal level theophylline level? Normal xanthine level, 10 to 20 micrograms per DL. Na pag uminom ka ng coffee at nagdatake ka ng gamot na ganyan, actually, pwede niya imimic, no? Magkakaroon ng false elevated result. No? So again, caffeine can cause, sulat ko lang, false elevated result. Thus, false elevated result, effect siya ng caffeine. Kaya avoid caffeine when taking xanthine derivatives. No? So anyway, okay. So paliwanag ko na, bakit sinabi mo, sir, that the only bronchodilator is epinephrine. Let me explain to you now, no? Okay. So ganito kasi yun. So again, ang pinag-uusapan, B2AA, tsaka xanthine derivatives. So ganito sila. Tika lang, okay? Ganito yung effect nila. Yung dalawang gamot na yan are actually known to be what? Natural they're called sympathomimetics, no? Once again, yung dalawang gamot na yan are called sympathomimetics. Which means they can directly stimulate the adrenal medulla. Kasi ganito yung discussion, ha? Okay? Normally, ang SNS activates the what? Adrenal medulla. Yung dapat yun, no? And ang adrenal medulla kasi is source ng epinephrine and norepinephrine. Yun siya, ha? Again, adrenal medulla is source of epinephrine and norepinephrine. Ito na ngayon, ha? Okay? Yung dalawang gamot na pinag-uusapan natin, yung B2AA, no? Yung beta-2 adrenergic agonists and xanthine derivatives can stimulate directly the adrenal medulla. So what? Pag na-stimulate ng dalawang yan, anong lalabas sa kanila? Epinephrine and norepinephrine. Ayun yun, no? Kaya nga siya lumalabas. Paglabas ng epinephrine is a natural bronchodilator. Therefore, what will happen then? Okay, it can cause bronchodilation, kaya siya bronchodilator. Sir, bakit din lang bigsaksakan ng epinephrine? Mahal naman masyado, no? Imagine mo ang primary drug mo, EpiPen, tsaka yung side effect niya. Kasi, okay, bukod sa it can cause bronchodilation, it can also cause what? Vasoconstriction. Can expect for mild increase in blood pressure, and of course, expect for tachycardia. And the most common side effect of the drug is tachycardia. Again, the most common side effect of the drug is actually tachycardia, no? So, magkakaroon siya ng tachycardia kapag nag-take siya ng gamot, no? Kaya hindi pwedeng gawing diretsyong epinephrine talaga ang gamot. One more time, ha? Okay, ang pinag-uusapan ito, bronchodilators only used for asthma. So, again, okay, so ano yung unang gamot? Yung B2AA, beta-2 adrenergic agonists, and xanthine derivatives, no? Now, okay, kanya-kanyang advantage at disadvantage. Yun nga lang, okay, ang B2A inhaler siya, mabilis gumana. And I'm telling you, pag mabilis gumana ang gamot, mabilis mawala yung effect. Na advantage ng kabila, xanthine derivatives, no? Okay, long half-life siya, lalo na pag na-maintain yung kanyang therapeutic level ng 10 to 20 micrograms per DL. Alright, okay, yun nga lang, avoid caffeine to avoid false elevated result. Now with that, let's talk about ito yung mechanism niya, ha. Yung dalawa can directly stimulate the adrenal medulla to release epi and norepi. Pag-release ng epi can cause bronchodilation, however, it can cause vasoconstriction, no? Again, can cause bronchodilation and vasoconstriction. So pag vasoconstrict, can cause high BP and tachycardia. Again, the most common side effect ng mga ganyang gamot, mga bronchodilators actually is tachycardia, no? Okay, so in the first management natin, bronchodilators only used for asthma. In the meantime, pangalawa actually is the respiratory therapy. Pag RT naman, ginagamit lang siya saan? Sa bronchitis. Bakit? Ang bronchitis kasi maraming plema, no? At ang goal ng RT actually is what? To clear the airways. Okay, sa bronchitis ang ginagamit to kasi ang goal niya to clear the airways. Huwag kang gagamit ng respiratory therapy sa asthma kasi wala naman siyang phlegm, no? Okay, dito ka sa maraming phlegm sa bronchitis kung tawagin. So again, the goal of that is to clear the airways. Now with that, okay, ano yung mga 3 steps natin for respiratory therapy? But again, yung ibang hospital sa Pilipinas, ang gumagawa ng RT, mga respiratory therapist na, no? Pero gusto kong i-discuss kasi minsan tayo pa rin pinapagawa. Na ano yung 3 steps? Unang-una, liquefy the secretion. What are the ways to liquefy the secretion? Paano magpalambot ng plema? Yung pinakamura, letter A, increase oral fluid intake. However, it's contraindicated pag may core pulmonal, syempre. Again, okay? Remember, core pulmonal, after all, is a right-sided heart failure. Bawal lang maraming water. Now, again, increase oral fluid intake is the first way to liquefy or loosen the secretion. Pangalawa, the letter B, is to what? To use humidified air, no? Gagamit tayo ng humidified air na madalas yan, steam inhalation o kaya nebulizer. Humidified air, pwedeng nebulization, pwede siyang steam inhalation. Yung traditional steam inhalation, pakulo ka ng tubig, no? I-inhale mo yung steam. Okay? And pangalawa, nebulization. Ginagamit pa rin siya hanggang ngayon, no? Now, letter C, pag di pa rin kaya, paano ayaw lumambot-lambot ng plema? Di mag-order ng gamot ang doctor. Okay? Anong gamot? Ang pampalambot ng plema actually is mucolytics, no? Paliwanag mo, however, that mucolytics will not remove the phlegm. It will just make the phlegm, the phlegm actually, loosened, no? Paliwanag mo, although, pag gamot ang pinag-usapan, as ordered tayo lagi. Again, okay? So, mucolytics as ordered to loosen or liquefy the secretion. Pangalawa, dislodge. Okay? Malambot na yung plema. Anong susunod? Dapat tanggalin sa pagkakakapit, no? So, how to do it? Letter A, pwedeng to CPT, chest physiotherapy, yung chest cupping natin, di ba? Ginagamit. Or letter B, through vibrations. Kasi nga, may limitations yung CPT. Okay, sulat ko ng buo. Pag sinabing CPT, chest physiotherapy, na minsan nurse pa rin ang gumagawa, no? Just chest physiotherapy. Yung chest cupping natin, no? Okay? Kinakap mo yung likod, actually. Okay? And then, by the way, ang problema sa CPT, hindi pwede yan sa taong may spinal cord injury, sa bleeding tuberculosis, and so on and so forth. Yung may mga back spasm, bawal. So, ang gagamitin alternative, vibration. Sabi nila, less effective, pero at least meron kang alternative than the chest physiotherapy. Now, in the meantime, pangalawa, pangatlo para, sige, una, lumambot na. Pangalawa, na-dislodge siya sa pagkakapit. Third, dapat ma-expectorate or ma-expel siya, no? So, what to do? Letter A, okay, is to engage the client to what? To cough. Now, how to do it? Okay, practice a DBCT, deep breathing and coughing techniques. Okay, actually, nagamit yan. O kaya naman, kung di pa rin kayang umubo ng pasyente, mag-order ng gamot ang doctor through what? Expectorants. So, administer expectorants as ordered. So, collaborative management ng mga to, as ordered siya, expectorants as ordered, no? Okay, at that. So, again, expel or expectorate through cough. How to do it? Okay, encourage deep breathing and coughing techniques. And also, we have expectorants as ordered. Now, letter B here, kung di pa rin kaya, gamitan ng gravity through postural drainage, no? Gamitan ng postural drainage yung pasyente. It's called postural drainage. Okay? Yung mag-gravity ba? Yung talagang para ma-expel yung, ma-augment yung removal ng secretions. Letter C, pag di pa rin kaya, sunduin mo na suctioning tayo. Suctioning, no? Okay. So, may few questions about suctioning. Ilang seconds ang suctioning? Actually, 5 to 10 seconds. Okay? Ideally. Now, what to do before and after suctioning? Hyperoxygenate or hyperventilate the patient. Again, suctioning tayo, ha? Okay. Ilang seconds yan? 5 to 10 seconds. And again, okay, what to do before and after suctioning? Hyperoxygenate or hyperventilate the patient. Now, when inserting the cannula, anong motion? Is it circular or linear? Ang sagot, linear. Pag inserting, ha? Again, when inserting the cannula, do a linear motion. Pag withdrawing, however, pag i-withdraw mo na, circular motion, applying intermittent pressure. Yung suctioning natin. Anyway, it's a concept for funda. Hopefully, it will be discussed in your funda. So again, expel, expectorate, cough, postural drainage, saka suctioning, no? Okay? With that, so that's the respiratory therapy. So, unang management kanina, bronchodilators. Pangalawa is respiratory therapy. In the meantime, pangatlo is oxygen therapy. Now, anong administration dapat? Low flow dapat to. Low flow oxygen, which means 1 up to 3 liters per minute, no? Some books would say 2 to 3, iba 1 to 2. Sama na muna na yun. Pagsamasamahin mo na 1 to 3 liters per minute. Now, why 1 to 3? Explain ko lang, ha. Now, delikado kasi pag nag-high flow yung pasyente, no? Again, it's very dangerous pag nag-high flow yung pasyente. Paliwanag kung bakit. I told you earlier, may dalawang centers tayo for breathing. Balikan ko lang ha. Ano yung primary natin? Medulla. Secondary is pons. Again, primary is medulla. Secondary is pons. Balikan ko lang yung topic na ito. Now, ang stimulant ng medulla is carbon dioxide. Ang stimulant ng pons is oxygen. So, yun siya dapat, no? Okay. Now, primary, secondary, CO2, O2. However, may however tayo ha. To a person with COPD or any other chronic lung problems. Again, to a person with COPD or any other chronic problems, shut down yung pons nila. Ulitin ko. Okay. So, ang primary center for breathing, medulla oblongata. Secondary is pons. And I'm telling you that sa taong may COPD or any other chronic lung problem, I'm talking about halimbawa ay cancer, no? O kaya naman tuberculosis, lahat yan shut down yung pons. So pag tinanong ka, what's the only center being used by a patient with COPD? The answer is medulla. Dahil wala siyang pons. Kumbaga, wala siyang generator, kundi anong meron siya, Meralco lang, no? Now, bakit low flow dapat? Simple lang. Kasi pag high flow yung pasyente, what will happen? It will eliminate all the carbon dioxide. So again, ang flow ng oxygen natin dapat low flow oxygen. Again, why is that so? Kasi again, pag high flow mo yung oxygen ng pasyente, it will eliminate all the carbon dioxide. Pag na-eliminate yung carbon dioxide, what will happen? Walang stimulant in medulla can cause respiratory failure. Again, okay? Dapat low flow oxygen. Why is that so? Kasi wala nga siyang pons, diba? Medulla lang meron siya. Okay? Therefore, anong purpose niyan? To retain carbon dioxide, no? To retain carbon dioxide to avoid to avoid respiratory arrest, no? Okay? Ang ultimate purpose niyan, retain CO2 to avoid respiratory arrest. Yun yung ating oxygen therapy. Na anong common methods of giving it? Unang-una, nasal cannula. Okay? Is the most economical. Pinakamura siya. Another advantage is that it mixes oxygen with room air. Ulitin ko yan, ha? Okay? So again, nasal cannula tayo. So una-una, economical, and also it mixes oxygen with room air. Pag venturi mask naman, it's the most accurate. It's the most accurate way of delivering oxygen. Some books will call it precise, no? Pareho lang yun, ha? Precise or accurate way of giving oxygen is venturi mask. Bakit siya naging accurate, guys, no? Okay? Kasi, kung anong sinet na liters per minute, yun lang papasok sa patient, no? Yun nga lang ganito. Okay? Yung nasa kanan na sa screen natin, yun yung venturi mask, no? If you would notice, para siya regular mask na may adapter. Yung kulay green is the adapter, no? Okay. Now, yung green na yan, hindi pwede sa COPD actually. Binigay ko ng example yan, na. Ang pwede sa COPD, blue lang. So, tanong sa exam, okay? Anong kulay dapat ng adapter ng oxygen ng taong may COPD? And I'm telling you again, is actually blue adapter, no? Again, the color adapter, I mean, for a client with COPD is the blue adapter. Why? Okay? Kasi ito yung mga adapters. Let me show you, the different colors of adapters, no? Ang pwede lang sa patient is low flow, diba? Which means 1 up to 3 liters per minute. The purpose of that is to retain carbon dioxide and to prevent respiratory arrest. Sige, tingnan mo. Ito yung mga adapters natin, no? Kanyang-kanyang color, kanya-kanyang ibig sabihin na. Like blue, ang pwede lang. Kasi nga, blue will deliver 2 liters per minute, no? Kasi yung white, 4 na siya. Yung orange, 6 na siya. Yung yellow, 8 na siya. Yung red dapat yan, 10 na siya. At yung green is 15 na siya, no? High oxygen level. So, bakit naging accurate? Kasi may adapter. Simple lang yan, okay? Example, nag-order ng doctor ng 2 liters per minute. Ang ginamit mo, venturi mask, no? Sir, di ba may regulator naman yung yung tangke? Yes. Anong problema lang minsan? Pinapakailaman ng pasyente yung tangke, no? At pag pinakailaman yan, tinaas na ng 5 yan, patay. Okay? Pwede magka-respiratory arrest. Kasi nga nahirapan huminga, eh. So feeling niya oxygen yung gamot niya, no? Well, tama yun. Treatment siya, however, which must be regulated properly. So ito ngayon, nakakinabit mo yung blue adapter. May regulator ka, naka 2 din, no? Kahit pakailaman ng pasyente yung regulator, ha? Lagay niya sa 10. Yung regulator, ang papasok sa pasyente, 2 pa rin. Kasi nga, meron siyang adapter to regulate the intake of oxygen. So again, okay, kinabit yung adapter na blue, ang papasok sa pasyente, 2 liters per minute. Kahit ilagay mo ng 10 yung regulator, ang papasok sa kanya, 2 pa din, kaya siya accurate way of delivering oxygen. So again, review ng konti. Ang flow ng oxygen, low flow. Ilan yon? 1 to 3 liters per minute. Anong purpose? To retain CO2, to prevent respiratory arrest. Now, pag nasal cannula, anong advantage? Economical, tsaka mixes oxygen with room air. Anong advantage yun, guys? Pag tinanggal yung nasal cannula, actually, sige, doon nakakabit yung nasal cannula, nag-mix yung room air, di ba? Pag tinanggal, hindi masyadong mag-a-adjust. Trivia, pag nilagyan ng venturi, ito yung ideal, Pag nilagyan ng Venturi mask yung pasyente, pag tinanggal yan, kailangan i-replace pa rin ng nasal cannula. Bakit? All throughout, sanay siya sa mask. Pag tinanggal mo, mahirapan yung pasyente, no? So, Venturi mask pag tinanggal, papalitan ng cannula para mag-adjust yung katawan ng client. Tinatawag ng weaning, no? Okay, weaning, parang weaning period ng baby, di ba? Weaning actually is required pag ginamitan mo ng Venturi mask yung patient. By the way, ang Venturi mask nga pala is a type of high flow oxygen system that can deliver low flow oxygen. So, pag tinanggal mo yan, kailangan kabitan pa rin siya ng Venturi mask, rather ng cannula, para makapag-adjust yung katawan to mix the oxygen with room air. That's oxygen therapy for us. Alright, okay. Meantime, another one here. Sige, first management, bronchodilators. Pangalawa, respiratory therapy. Pangatlo, oxygen therapy. Pang-apat na nutrition, diet ng pasyente, no? Okay? Hindi pwedeng mag-large volume feeding patient, hindi pwedeng maraming kainin, no? Bakit nga I told you? Pag kumain ng madami, nahahapo, napapagod siya. So therefore, dapat yan small, frequent feedings, no? SFF. Again, okay? Gagamitin dapat small, frequent feedings na preferably soft diet, no? So anong kailangan sa diet niya? Well, okay, wala namang naka-specify, basta maganda, well-balanced diet. Bakit soft? To avoid too much mastication. Okay? And of course, we engage small frequent feedings para hindi mahapo yung pagkain ng pasyente. As much as inaabot siya ng 6 to 10 times per day, no? Kahit paunti-unti lang, at least ma-meet yung kanyang nutritional needs actually. That's the nutritional of the patient, no? At that. Now, next management. Okay, again, simple lang, nutrition, walang specific kung low calorie siya, high calorie, no. Okay, ideally, syempre, kung madaling mapagod, sana high calorie, no? Pero wala naman naka-specify sa books. Sabi lang, small, frequent feedings, preferably soft diet. To avoid too much mastication, kasi pag gunya, nakakapagod sa pasyente. Now, another one there, okay, is coping and relaxation. Why? Remember, ang cause ng asthma, actually are allergens. And remember, allergens has two types, intrinsic, tsaka extrinsic. Anong intrinsic nga? Anxiety or stress. Can you avoid stress? No and never. Again, okay? So, dapat yan, coping and relaxation. Why again? Kasi ang cause ng asthma, pwede intrinsic, pwede extrinsic. Pag intrinsic nga ulit, anxiety or stress. Again, pag intrinsic anxiety or stress, okay? How do you battle that anxiety or stress? Can you avoid it? No, but coping and relaxation. Kaya wag ka na magtaka kung bakit yung mga taong may asthma madalas nire-refer sa mga psychologists, no? Hindi sila baliw, but they are being taught how to cope. Now, in the meantime, another one here, okay, is yung position ng patient, no? Kaya ang mga therapy, well, sa psych na yan, no? Psych discussion, actually, alam mo yung mga yan, yung mga musical therapy, yung mga play therapy ng bata and so on, no? In the meantime, yung position, no? Okay, we have two positions, actually, high fallers or orthopneic position. Both have something in common, whereas anong purpose nila? To facilitate maximum air exchange. And the purpose of that is to facilitate maximum air exchange. One more time, okay? Ang purpose nila to facilitate maximum air exchange, no? Okay? Yun nga lang, sige, pwedeng high followers A here, pwedeng B here. Kaya lang, pag tinanong ka sa exam, paano sir, kung parehong lumabas yung A tsaka B? Well, mas maganda isagot yung B. Anong tawag yan? Orthopneic position. Bakit? Okay? Kasi naman, mas comfortable siya. Kung ayaw mo maniwala, mamayang gabi, pag natulog ka, subukan mo na ka high followers ng ganyan, no? Pag di ka nangawit, no? Okay? Sinulit ko, okay? Again, pag nalumabas, positions are either high followers or orthopneic position. What's that again? To facilitate maximum air exchange. And again, I'm telling you that, okay? Anong mas advisable dyan sa patient? Orthopneic, kasi meron leaning on over a bed table, di ba? Mas comfortable yan kaysa sa high followers na talagang naka-angle ka ng 90 degrees, no? So again, okay, pag lumabas pareho, the best answer is letter B, orthopneic position. Now, in the meantime, another one here is tinatawag na IPPB. Naandyan na siya, tinatawag siya intermittent positive pressure breathing. IPPB, or some books call it IPPV. Instead of breathing, it's actually ventilation, na. So IPPB or IPPV. Alright, intermittent positive pressure breathing or ventilation. Now, ginagamit lang guys sa emphysema. Now, anong trouble ng emphysema nga? Hindi makatanggal ng carbon dioxide kasi ayaw mag-deflate ng alveoli. If you would recall that, again, okay? Ang trouble sa emphysema, hindi makatanggal ng carbon dioxide kasi ayaw mag-deflate ng alveoli, right? So, gagamitin siya ng IPPB or IPPV. Anong purpose yan? To actually force out carbon dioxide. Again, the purpose of that is to force out carbon dioxide. However, dito kailangan i-monitor yung ABG, no? Okay? So that ABG must be monitored. Again, ABG must be monitored back. Why is that so? Bakit kailangan i-monitor ABG? Kasi nga, okay, pag nagtanggal ng CO2, pwedeng sumobra yung tanggal ng CO2 can lead naman to respiratory alkalosis. Kaya nakalagay dyan, okay, at nilagay ko na actually is monitor for the ABG Again, for possible respiratory alkalosis. Okay? Yun yung mga discussion natin for that. Okay? For IPPB, no? Annex management. I hope you're still okay. Okay? Nakaka-overload itong mga topics na ganyan, pero walang choice dahil kailangan natin sila for our exams, no? With that. So again, IPPB is only used for what again? Emphysema. And the purpose is to what? To force out carbon dioxide. Okay? Yung nga lang, what to monitor? ABG for possible respiratory alkalosis. Now, another management, okay, is avoidance of allergens. So, question, okay, anong cause ng allergy? Allergens. Dalawang klase, intrinsic tsaka extrinsic. Pag intrinsic, anong panglaban nga ulit? Is actually avoidance of allergens. Okay? Pag extrinsic naman, anong panglaban sa kanya? Extrinsic, eto na, syempre, pag intrinsic, mga inhalants, ingestants, contactants, ganyan, edi malamang avoidance of allergens. Okay? Delikado na i-challenge yung katawan, no? Delikado yan, no? And mali-discuss yan sa may immunology kasi it may lead to possible shock or anaphylactic shock. Basta, one thing for sure, allergic ka sa hipon, wag siya nga. Iwasan mo na yung hipon. Allergic ka sa boyfriend, wag naman sana, no? Okay? Anyway, in the meantime, another one here are the different lung exercises. Okay? Sige. Ang taong may COPD, any of them has laborious breathing. I told you about that. Pag sinabing laborious breathing, ang ginagamit nila, balikat. Imbis na diaphragm, balikat yung kanilang ginagamit. Thus, pag inhale sila, umaangat yung balikat, lalong nakakapagod yun, no? Hindi nila alam yun. Akala nila nakakatulong, pero hindi. Nakakapagod. So, dapat gamitan ng breathing exercise, no? Okay? Diaphragmatic breathing. The good thing is that, since exercise yan, pwedeng matutunan ng pasyente. Pagsasabayin ang gamit ng diaphragmatic breathing and pursed lip breathing. And the purpose of that pursed lip breathing, by the way, ito, ang purpose niyan to avoid the use of accessory muscle. Pag pursed lip breathing, ang purpose niyan to expel more carbon dioxide. To expel more carbon dioxide. Yung purpose ng pursed lip breathing. Okay? Anong I ratio niya? 1:3. So, mas mahaba ng 3 times yung exhalation than inhalation. Kasi nga, ang goal natin to expel off carbon dioxide. So, madalas ganitong ginagawa dyan, no? Okay? Yung pasyente, hirap huminga. So, ang kamay niya dapat nasa abdominal area, nandito sa abdomen, no? So, again, yung pasyente, yung kamay niya nandito sa abdominal area. Para malaman niya, nang aangat sa kanya diaphragm, hindi yung balikat. Pag nag-inhale yan, gagamitin yung nose niya hanggang mag-maximum inhalation, no? Mag-maximum expand yung lungs. Pag exhale niya, using the pursed lip, ganun dapat. Para mas mahaba yung exhalation, hindi pwedeng ganun, no? Dapat yan mas mahaba yung exhalation ng 2 to 3 times than inhalation. So, yun. Para ang goal niya, again, to expel more carbon dioxide. Okay? That's the purpose of it. And in the meantime, we have here the next management. So, yun yung lung exercises, no? The purpose again, unang-una, diaphragmatic breathing. Para ibalik sa diaphragm, hindi sa yung breathing wala sa balikat, no? Kasi nakakapagod nga pag nasa balikat yung breathing niya. And also have pursed lip breathing to expel more carbon dioxide. Iyatin ang IE ratio of 1:3. Okay? Therefore, 3 times mas mahaba yung inhalation kaysa sa exhalation, no? Okay? And then anyway, let's continue on. Let's discuss now the next topic about that. Let's talk about the next one is cromolyn sodium, no? Okay? Ano yung cromolyn sodium, guys? Ang cromolyn sodium actually is a mast cell stabilizer. Sige, review ng konti, ha? Okay? Pag pumasok yung allergen, again, pag pumasok ang allergen, dalawang klase, intrinsic tsaka extrinsic, okay? It will cause the release of IgE that will actually destroy the mast cells. Again, nasisira yung mast cells natin, no? Okay? Pag nasira yung mast cells, anong mangyayari nga sa kanya is that magkakos siya ng release of histamine 1, which can cause bronchoconstriction tsaka vasodilation. Now, okay? Ang intrinsic allergens, what to do again? Coping and relaxation. Pag extrinsic naman, avoidance of allergens. Again, intrinsic, coping and relaxation. Extrinsic is what? Okay? Is avoidance of allergens. Ito, coping relaxation. Ito, avoidance of allergens. IgE, walang gamot yan. In fact, tumutulong siya, remember? Okay? However, itong mast cells, pag nasira, labas ang histamine 1. So, ginagamot na yon, no? Okay? May tinatawag na cromolyn sodium, a mast cell stabilizer. What for? Para lumakas yung mast cells, para hindi masira, to avoid the release of histamine 1. Now, by the way, okay, anong route niya? Via inhaler siya. Again, its route is via inhaler. Via inhaler siya. And by the way, okay, it's on a white container this time. So, again, yung bronchodilator kanina, blue container, yung white is mast cell stabilizer. I told you, hindi basta-basta magbigay ng kung ano-anong kulay, no? Kanya-kanyang kulay, kanya-kanya ang meaning. In fact, okay, let me amplify that. By the way, nga pala, paki-take note nga pala, if you're writing or if you have it in your mind that, okay, this is only a prophylactic drug, no? Again, it's a prophylactic drug. It's not taken during acute attack, but it's a prophylactic drug. Okay? So example, meron siyang allergy sa sa bulaklak. Aakyat ang Baguio, may parang nagbenga festival. Anong gagawin niya muna? Okay? Mag-pop muna siya ng cromolyn sodium bago umakyat. Mahal nga lang talaga yan, no? Kasi isang ganyan, 3,000 pesos yan, no? Pero sure, wala siyang attack kasi nga hindi masisira yung kanyang mast cell. But again, only used for asthma, not for bronchitis, not for emphysema. The meantime, another one here, ito yung mga gamot na, yung magic 6 ng ating emphysema, no? Okay? Yung administer medications as ordered, yung unang dalawa sinabi ko na. First are the bronchodilators. Na pag binigay via inhaler, okay, is actually what? Okay, is a blue container. Pangalawa, mast cell stabilizers. Ito yan, no? Kasasabi ko lang yan, that's mast cell stabilizers. Okay, that's mast cell stabilizers. Okay, yan siya actually, no? Now, pangatlo, ito na, by the way, pangatlo sa question, yung asthma, remember, yung bronchitis, remember? Itis, meron siyang inflammation. Obviously, gagamitan siya ng anti-inflammatory. In so far known to us, what's the strongest anti-inflammatory are corticosteroids, no? The corticosteroids will be used as corticosteroids actually are being used. Okay, steroids tayo na. By the way, given siya via inhaler. On what container? Violet or purple container. So again, pag blue, bronchodilators. Pag white, mast cell stabilizers. Pag purple, corticosteroids. Sir, may nakita akong dalawa pa, no? Meron akong nakitang red tsaka green. Sige, okay? Idagdag ko dito sa next, no? By the way, pag nakita ka ng brown, huwag mong gamitin kasi kape yan, no? Starbucks. So, idagdag ko, ha? Okay? So, pag blue, bronchodilators. Okay? Pag white, mast cell stabilizers. Pag purple, steroids. However, pag nakakita ka ng red, no? When you see red, okay? Ano yan? Actually, is a what? Form of, is a steroid. Corticosteroids with bronchodilators. Again, pag nakikita ka ng red, like seretide, no? Okay, ano yan? Red yan, steroids with bronchodilators, no? However, pag nakikita ka ng green, pag green, ano yan? Ano naman siya? Bronchodilators with steroids. Tingnan mo guys, ha? Okay, therefore, pag red, mas maraming steroids. Pag green, mas maraming bronchodilators. Okay, yun yung mga specification ng colors ng mga inhaler natin or yung puff ng pasyente, no? At that. Okay, now say, ulitin ko ha. First drugs are bronchodilators. Pangalawa, mast cell stabilizers. Pangatlo actually are corticosteroids, no? Nala sila via inhaler. Pag blue nga ulit, ano siya? Bronchodilator. Okay, pag white, mast cell stabilizers. At pag purple, corticosteroids. Pag red nga ulit, ano siya? Steroids na may bronchodilators. Pag naman siya ay green, bronchodilators na may steroids na. Okay? And then another one. So question, pag may bronchitis ba, hindi pwede magkaroon ng infection yung pasyente, right? Kasi pag nagkaroon ng infection yung pasyente, lalong dadami yung kanyang phlegm. Therefore, anong ginagamit sa kanya? Antibiotics, na. So next one here given, ito yung antibiotics, na. Now, so anong specific? Walang specific antibiotics given to a client. Depende lang sa need ng patient, na. That's antibiotics, na. Okay? Na dalawang purpose niya, pwedeng therapeutic. Pag meron siyang active infection, therapeutic purpose, at pwede rin siyang prophylactic, no? Pwedeng prophylactic, pwede rin siyang therapeutic effect actually. Now, in the meantime, okay, we have here the next one. So, a question, okay? Recall tayo ng konti. Ito, nakasulat dito, no? Pag anong cause ng allergy? Allergens. Pagpasok ng allergens, palalaban ng katawan by IgE. Destroying the muscles can cause release of histamine 1, no? So, isa pang gamot niya to revert that histamine 1, actually antihistamines, no? Okay? So, this one are antihistamines, which are usually taken oral route, no? Pareho lang yan. Pwedeng prophylactic, pwede ring therapeutic, no? Yun nga lang, can cause possible sedation. Now, okay? Last one here. Paano yun, sir? Pag nagkaroon lang siya ng bronchoconstriction tsaka vasodilation, anong drug ang pwede ibigay to reverse the two? Ang sagot doon, epinephrine, no? Yan, medyo malaki lang yung risk niyan kasi ang gagamitin EpiPen, no? Watch out there first. So, pag nag-epinephrine ng pasyente, monitor the vital signs carefully, no? Okay? And by the way, tanong sa exam, anong tawag sa calibrated dose ng epinephrine? Ang calibrated dose ng epinephrine, tinatawag siyang EpiPen. Again, what do you call the calibrated dose of epinephrine? Tinatawag siyang EpiPen. Okay? It's actually calibrated dose of epinephrine. Now, with that, okay, yun yung mga gamot natin for COPD. Now, okay? In the meantime, let's go and discuss now the next one. So, next management tayo. So, of course, we have, ano pa is what? To remove pulmonary irritants, and topping the list is actually cigarette smoke, no? Okay? Let me show you a video and to show you actually, oops, hindi yan. Mali. Hindi rin yan. Ano ba yan? Nagkagulo-gulo na ako. Okay, let me show you a video, no? Okay, nung campaign ng World Health Organization against cigarette smoking, no? Okay, pakita ko lang, hanapin ko lang yung video, guys, ng ating discussion. Ito siya. Panoorin niyo yung video to,
พี่ขอไฟหน่อย ขอไฟหน่อย พี่ขอไฟหน่อย
หนูดูดเองจริงเหรอ
ไม่ได้หรอกมั้งอายุยังน้อยอยู่
เป็นมะเร็งเนี่ยต้องไปเจาะคอไม่กลัวหมอผ่าตัดแล้วน้อง
บุหรี่มันมียาพิษอยู่นะ
มันทำให้หน้าเหี่ยวด้วยนะ
สูบบุหรี่แต่ก็ตายเร็วไม่อยากอยู่เล่นนานๆอ่ะ
มันไม่ดีรู้เปล่า สูบแล้วเป็นทั้งมะเร็งปอดถุงลมโป่งพอง
ไม่ดีแล้วพี่ดูดทำไมล่ะคะ
Project sa Thailand, actually, tingnan mo nga naman, paano nga naman kung kapatid mo yun nag-smoke, no, hingi ng pang-yosi sa'yo, no? Kasi sabihin, masama yan, smoker ka, di wala. Okay, yung modeling na. Anyway, that's actually a management known as is to avoid, again, remove pulmonary irritants, stopping the list. Ikakamatay talaga ng pasyente, no? Pag nag-smoke pa siya. Na last management here, okay, is to actually encourage rest. Kasi siyempre to conserve energy, conserve oxygen, you have to encourage rest to the client. Okay? So yun yung mga management natin, management for COPD as a whole, no? Okay? So let's review a bit, no? Review natin yung mga management natin. Okay? So with that, sige, let's review the management here. Ano yung unang binigay ko kanina actually are, enumerate ko lang guys para may guide tayo, no? Okay, so ano yung mga management natin are the following. Unang-una is bronchodilators, no? Okay, that's bronchodilators. Sige lang, okay. Ito lang gagawin ko. Sige, ano yung unang kanina? Bronchodilators, right? Followed by respiratory therapy, oxygen therapy, ano pa? Nutrition, coping and relaxation, high fallers or orthoptic position, intermittent positive pressure breathing, lung exercises, okay, cromolyn sodium, administer medications, remove pulmonary irritants, saka encourage rest. Ang mnemonic na bronchial of COPD, or management of COPD. Okay, we're done discussing the Respi concepts, okay, from kanina, from the discussion, I mean, of pulmonary, shall I say, pneumothorax, then pleural effusion, and then this time is actually COPD with 3 disorders: asthma, bronchitis, and emphysema.